The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Dr. Robert Hendren is a professor of psychiatry and behavioral science at UCSF Weill Institute. He's worked with individuals with ASD for more than 40 years. He is a member of the board of directors at the Autism Research Institute.
Thanks, Denise. Nice to be with all of you. I guess we can't all see each other. It's not like a regular audience talk, but I think we're all getting used to doing these Zoom visits with each other. And although three-dimensional is better, two-dimensional is better than just a voice. So nice to be with you today. I have been struck in the past few years with seeing more and more young people and hearing my colleagues talk about young people who have, and people actually that are young people and young adults and others with autism having catatonia, catatonic autism, or catatonia in autism, and also seeing more and more kids with what's called disruptive mood dysregulation disorder. And as I was preparing for the talk and thinking about what to talk about, it started off being just catatonia. And I thought, well, you know, we see both of these more often. And are there some similarities? Or are there some things that could stimulate our thinking about how to understand this co-occurring catatonia or DMDD with autism? And could that help us think about ways of treating it better or understanding it better? So what I plan to do today is start off talking about catatonic autism, you know, the way the diagnosis has come about. I guess I'll say first that I have grants from different companies, different organizations. I'm on advisory boards, and I get royalties. None of those have direct relevance to anything I'm going to talk about today, but just so I've fully disclosed, here it is. I want to talk first about catatonic autism, a description, some of the recent publications, and there have been two large case series reported just even in the last year. Talk a little about treatment, and then I'll describe some cases, some people that I've seen that I think represent the broad spectrum of people that might be called or might be said to have catatonic autism. Then I'll do the same for disruptive mood dysregulation disorder. Talk a little about its history, its definition, some of the controversies about the term. Talk about the overlap with autism or the spectrum of autism. Talk a little about treatment and then cases. And then at the end, I'm going to really go out on a limb and just kind of speculate, just kind of say, why are these things emerging now? Wonder and give you some information. I don't have the answer about what similarities or overlaps might they have. But I'll present a treatment model that I use in my practice and ways of thinking about both of these disorders. And if some of you have some interest in this area, then perhaps maybe when we get to the discussion, you can tell me your thoughts about that, or you can ask more questions about it and we can talk. But the last part of the talk is not meant to be hard science. It's meant to be more thinking out loud for all of us to hopefully interact and think about. So catatonia historically was thought as being something that was associated with schizophrenia. I remember when I was a medical student going to state hospitals and seeing people with schizophrenia that had what we referred to as waxy flexibility, or you could move them and they'd stand like a statue for hours. You could move things around and they felt waxy. And I think in that time, we thought of catatonia as being really associated with schizophrenia. But in DSM-4, catatonia was thought of as being a unique medical condition that cuts across different disorders. So it's not subsumed by schizophrenia, but could also be seen in mood disorders. And then in DSM-5, it began to be thought of as even broader than that. It was really defined by 3 symptoms, which we'll talk about in a minute, from a list of 12. And schizophrenia can be a specifier, but there can be other specifiers as well. And then there's a catatonia not otherwise specified. So DSM-5 talks about catatonia associated with another mental disorder, or it can be associated with a medical condition that's not necessarily directly related to a mental disorder, or there can just be unspecified catatonia. The symptoms that we see and that are listed in the DSM-5 talk about cataplexy, that way that people could hold a posture, even held against gravity. I remember, years ago seeing somebody that the person took him out of bed, stood him there, and he stood like a statue for over an hour. But I sometimes see young people now with autism or with other disorders that have that same kind of, they just stand, and they stand there for a long time and they don't really move. And you can move their arm, and their arm will stay in the position you move it to, that waxy flexibility as it's called. They often have a kind of stupor. There's not really any expression, no reactivity to the environment, no back and forth interaction. But while that stupor was what was classic for catatonia, now people say or in the classification, there's also a kind that can have to do with agitation. Agitation that's not really in reaction to being frustrated or somebody doing something that they really don't like, but just agitated, just kind of moving and bouncing around a great deal, randomly agitated. It can also be associated with mutism, that people with catatonia have no or minimal verbal response. And then a kind of negativism, opposing or not responding to stimuli or instruction. While it looks like negativism sounds like you're being oppositional, it's more as though they're just not reacting. They hear it, but they don't respond. They don't do anything, and they don't, if you're walking and they stop, you say, come on, move, and they don't move. It's as though something just stopped with them. There's also, as I'd mentioned, this kind of posturing, a way of standing in a particular posture, and then mannerisms, odd caricatures of ordinary actions, a way of exaggerated kind of movements or poses that in some ways you could think funny unless you kind of recognize that this just wasn't being done to be funny. Or stereotypies, repetitive, frequent, non-goal-directed movements. And grimacing, a kind of facial grimace that you see that these people squint up their face when they're going through this. And then echolalia, repeating words, or echopraxia, mimicking movements from the examiner. So those are the criteria in DSM-5. It can be associated with a variety of disorders, but it can be associated with autism, and that's what we're going to talk about now. In a study that was published last year by Dr. Wachtel at Johns Hopkins, she described 22 patients with autism and catatonia over a 12-year period. There are 2 main people that write a lot about or have been authorities on catatonia and autism, Dr. Wachtel and Dr. Dhossche, who we're going to talk about in a few minutes. The 22 patients were comprised of 6 girls, 16 boys. They ranged in age from 8 to 26 years. All but one of the patients had been tried and treated with a benzodiazepine, which is almost always lorazepam. We'll talk about that in a minute. From doses that range from 1, a relatively low dose, to as much as 27 milligrams, which is a walloping large dose. But all but one were treated, but all of them did not experience enough benefit. So they had ECT, electroconvulsive therapy. In this case series and another we'll talk about in a minute, talk about ECT for catatonic autism. The mean age of starting it in this case series was 15.6. Total numbers received range from 16 to 688. It was reported to show clear benefit in terms of the catatonic symptoms by reducing them, and it included alleviating of these incapacitating treatment-resistant self-injury. So I think some consider it a pretty dramatic treatment, and they think, oh my gosh, ECT. But in the cases that I'll describe, I'll talk about families who started out really not wanting to go there, but when everything else had been tried, then they said, well, I don't want my child or my young adult to continue to go on this way. And so they consider ECT. And some states make it easier to get that than others. The most common catatonic symptoms that she reported included agitation, stereotypy, posturing, negativism, mutism, stupor, and grimacing, with the number of catatonic symptoms ranging from 2 to 8. It was also associated with intractable self-injurious behaviors that she proposed, and others have as well, as an additional sign of catatonia. People that do things like hitting themselves or biting their nails way down, way too far, or other kinds of self-injurious behavior. Of the patients treated with benzodiazepines, the reasons for discontinuing were most commonly no symptom reduction or only partial symptom reduction. But for another number, it was sedation. And for a lesser number, but still a significant number, 9.1%, a worsening of the behavior from those symptoms. Now, Dhossche, who I mentioned is at the University of Mississippi, he was one of the first people to describe catatonia, and he described using ECT in a series of his patients in a paper that was again published last year, 2019. And he points out that in its malignant form, when catatonic autism is really not doing well at all, they can have autonomic dysfunction that includes fever. It may become acute and is potentially life-threatening, but it's treatable with ECT. So it warrants the prompt diagnosis and treatment first with benzodiazepines, using what we'll talk about in a minute as a lorazepam challenge, or lorazepam's brand name is Ativan, as a first-line treatment, and ECT as a second and more definitive treatment. According to these two experts, that I think for sure have at least reported more cases than anybody else has seen, but there are many people that have seen lots of people with catatonic autism, and as I say, I'll describe a few from my practice. The catatonia helps children. This again is from Dhosche's case series, with concurrent medical conditions as well, including things like lupus, NDNA receptor encephalitis, psychotic and affective disorders, toxic states, autism, developmental disorders, tics, PTSD, and then Klein-Levin syndrome, which is a odd, rare syndrome where people can sleep up to 20 hours a day, do that for a few weeks, and then don't. Or what he referred to as a pervasive refusal syndrome, where people just refuse everything. And in the the differential diagnosis, that what you need to think about when you're wondering, is first what's referred to as akinetic mutism, meaning people are mute, they're not speaking, but they're also not moving, or non-convulsive status epilepticus, the idea that you're having seizures that are subclinical, not seen from the outside, but if you connect to an EEG, you can see that this person is having seizures a lot of the time, which can make them look catatonic. Locked-in syndrome, where often as a result of stroke or other kinds of brain accidents, people are not reacting, but they're still going on in there. The stiff person syndrome, which is kind of what it's described, Parkinson's, stroke, delirium, dementia, elective mutism, and as I mentioned before, NMDA receptor encephalitis. There are some rating scales that have been devised. One of the first was this Bush-Francis Catatonia rating scale, and then the pediatric Catatonia rating scale was an adaptation of that to be able to be used more accurately in children. And it includes people who have developmental and communicative delays, and mostly is asking about those things that I went through as the symptoms in the DSM-5. There's also a Canner rating scale that's proposed to diagnose catatonia and neurodevelopmental disabilities, and was published a bit later than the first two that I've mentioned. When these experts and others talk about what might be the etiology of this, what could be causing catatonic autism, one of the unifying pathogenesis models is, it's kind of elusive, but theories talk about some dysfunction of motor circuitry, epilepsy, neurotransmitters, genetics, endocrinology, immunology, traumatic fear. We'll talk a little bit more about a few of those because that's a pretty broad range. They talk about a vagal theory of catatonia having to do with the vagus nerve and the way that it affects the autonomic nervous system, that these aspects suggest further study of autonomic dysfunction and the use of anticholinergic agents and perhaps even vagal nerve stimulation, and was first mentioned in a classic paper in 2003, but has been mentioned a number of times since. Also, the response to benzodiazepines makes one think about GABA dysfunction. So benzodiazepines affect GABA aminobutyric acid, and it suggests that GABA, this excitatory, inhibitory back and forthness between GABA and glutamate that we'll talk more about at the end, might be something that's really helpful in understanding autistic catatonia. It's helpful in understanding autistic behaviors too, and that these may then suggest that there may be better benzodiazepines or more newly developed benzos that'll help us with catatonia more than lorazepam, although lorazepam helps, at least at first, but usually it's not quite enough. So just to add a bit of intrigue to this is not necessarily a seminal study or one that answers things, but it's a study looking at things like trace elements that are found in hair and in other parts of the body in people who have catatonic autism, suggesting that perhaps there are things in the environment, perhaps there's ways of getting exposure to things like mercury or iodine or aluminum or a variety of other things that showed up in this study looking at hair for trace elements that go through your body, get kept in your hair so that they're there for longer, and is a way of wondering whether there is either more exposure or more difficulty metabolizing some of the trace elements that we're exposed to, and has been postulated as a potential cause of autism, but has not totally been unequivocally proven in replicated studies. But here's one looking at catatonia and autism, again talking about these trace elements that show up in hair at sometimes higher and sometimes lower levels. And these would suggest that there is some association and reason for an association with these in autism and catatonia. Interesting to me, too, was Wachtel in the 2019 paper referred to several studies in the United States and Europe that demonstrated catatonia occurs in between 12 and 20% of individuals with autism. And they're documenting a full range of psychomotor agitation and retarded catatonia and autism, including intractable self-injury. You kind of wonder if maybe the people that report those figures have a reason that they attract a number of people that have those symptoms. They're expert in the area, or more people come, because in the autism clinic that I work with at UCSF, I wouldn't say the prevalence is anywhere near that. And when I talk to my colleagues, people don't say that they see that much in their practice, but that is what's reported in 4 different studies reported by Wachtel, saying this is fairly common in autism and suggesting that we ought to be looking carefully for it. In looking at it, we look at the medical workup. We try to look at the basic hematologic and metabolic measures, but also look for drug testing, brain imaging, autoimmune antibodies, things like lupus serology, looking at ANA, pandas serology, looking at anti-NMDA receptor antibodies, and other tests that might be guided by clinical examination. But most children with catatonia are not really found to have an underlying defining medical condition, but some do. And it's important to rule that out, to know, is there a medical condition that might account for this and should be treated, especially if your next step is going to ECT, to say, I want to be sure I've ruled out all the medical causes before we start doing ECT. The treatments for catatonia, as I've mentioned, start with benzodiazepines, anywhere from 10, but I'd said before 1, but one starts slowly and works their way up. But you can actually often, I find, work your way up pretty fast. It's amazing. Most of us, if we were to take, say, 10 or 20 milligrams of a benzodiazepine, would be totally out of it for days. It would just totally knock us out. And for these kids that I've seen that I wonder if they have catatonic autism, or I think that's what they have, I've gone up to as high as 24 milligrams. And I have colleagues that tell me they've gone up to more, like here they're saying the upper limit being 30 that Dr. Wachtel reports. And there can be a fairly immediate response, which is what this lorazepam test is, giving people lorazepam, Ativan, in 1 to 2 milligrams, either by mouth or intramuscularly or even IV, to say, does this result in a significant improvement in their symptoms? And that is not a definitive diagnosis, but it certainly suggests that catatonic autism is highly likely, because anything else would be extremely sedated by taking that. But these high doses, in my experience, while they may work for a while, don't work forever. And so then one comes back to saying, well, what about ECT? Should we consider doing that? And in those cases, we think about the guidelines that the child should have, or the patient should have, an ECT responsive medication. The AACAP is the American Academy of Child and Adolescent Psychiatry. that there's a high illness severity. These kids are really not doing well. And there are 2 failed medication trials. There are other medications that might be considered. Memantine is a medication used to treat the NMDA receptor in Alzheimer's disease. And some people have reported benefits from that, often in combination with other medications. Lithium has been reported in 2 cases where kids had a SHANK3 genetic abnormality, and in those 2 cases that were reported. Quetiapine is also called Seroquel, is the brand name, is reported to have helped one autistic patient with autism and comorbid bipolar disorder, along with a basal ganglia calcification. And then lorazepam, fluoxetine, and packing therapy was reported in pervasive developmental disorder and catatonia in a French study. As you know, packing is a controversial treatment where people are put in wet, cold sheets. And it's been denounced by some, but I have been to Paris and seen people do it, and it's not cruel and unusual, but it's kind of it is certainly unusual. It's not necessarily these kids are not mistreated, but that's another treatment that people have tried. So let me tell you about a couple cases. First is a 10-year-old boy who had PDD-NOS with a lot of anxiety, depression, anxiety, violent outbursts, had really severe OCD and increased non-specific movements, followed by decompensation and function, mutism, decreased movements, and agitation. So you can see a number of those symptoms that we've talked about already. There's a question of psychotic catatonia, possibly PANS. He was worked up for PANS, did not clearly show that, but was treated with IVIG, which resulted in worse obsessions. SSRIs made him worse. Probiotics, curcumin, and multivitamins were all tried without benefit. Quetiapine and lithium without benefit. At age 13, he began to freeze in place and tremble. At age 14, he started to seem psychotic, not in a classic way, but psychotic. The diagnosis of PDD-NOS was made, an anxiety disorder, NOS, and obsessive compulsive disorder. Had a pregnancy and labor and delivery that were without complications. Milestones were on track. He has increasingly variable obsessions, and he had a head injury without loss of consciousness in preschool. Previous testing showed lower cognitive testing that had diminished over time. He showed initial improvement with lorazepam. He was a patient we saw at our clinic, and he did improve with lorazepam. But the family felt he was doing worse and went to see this Dr. Dhossche at the University of Mississippi that I described earlier, who diagnosed excited catatonia, gave him a course of ECT and lorazepam with aripiprazole, which in the report sent back to us afterwards said almost completely eliminated the catatonia. After leading what the parents described as a normal life, taking aripiprazole and lorazepam, this was in about 2014-15, but in 2016 we received a report from the University of Utah where they said that he was being hospitalized and treated for schizophrenia, Tourette's, OCD, and autism spectrum disorder. So it made us wonder, are the outcomes as good as people say? And do they last? The next case is a 26-year-old young woman who I saw for a number of years with autism, and ultimately we felt catatonia with OCD. She was a product of an unremarkable pregnancy, labor and delivery milestones were okay. Her elementary school, she was thought of as shy. In middle school, she became less and less verbal. In high school, a counselor became concerned that she was not socializing, but she got good grades. Parents said mostly straight A's, but she began to have a loss of language and functional skills. When we saw her in her late teens, she had no eye contact, was withdrawn in the room, little movement, had facial grimacing, self-injurious behaviors, had her hair over her face, communicates with grunting or with growling. And she had full evaluations, was diagnosed with autism. 24, when these things continued, she had an MRI and an EEG that were read as normal. She had lost a dog. Her dog died, and she became totally nonverbal after that. She was treated by us and by others with multiple high doses of SSRIs, antipsychotic, and mood stabilizers. Genetics saw her. She was found to have a normal karyotype. They fished for 15q11 and for 22q11. They were negative. They did a CGH, which was unrevealing. All the other tests that you see up there. At the time, the diagnosis of childhood disintegrative disorder was made, even though it was taken out of the DSM-5 and wondered about schizophrenia. When we saw her again, we titrated her up on lorazepam to 18 milligrams. She showed steady and significant improvement, became conversational in her speech, began to interact with others, going out of the house, full self-care. But when we titrated down to 4 milligrams, she began to do less well. She's been maintained on 3 milligrams, fluoxetine, Prozac 60 milligrams, added in a little bit of clomipramine, with a little bit improvement, but not to the initial level. Tried memantine, still very OCT, not working well. And family then finally said, okay, we're ready to try ECT. Referred her to the person in our group who does ECT at UCSF. She was seen 3 times a week for 3 weeks with no benefit. It's been a discouraging thing. Nothing has quite worked. We've wondered now about lithium and about TMS. I'm going to skip the third case in telling about it in detail, except to say this is a 21-year-old male, had normal development, seemed to get less and less functional, less and less able to do things like crossing thresholds, engaging in rituals. And we can come back to this case at the end if you'd like. I just realized that I'm getting into telling stories and want to leave time for us to have discussion at the end. But this is a boy that has just been heartbreaking to me because I've seen him for quite a number of years. First, when I was at the Mind Institute, and then they followed to see me here. We've tried everything, every medication we can think of. He still gets frozen, and he's seen 3 neurologists. They all refer to what he has as catatonia. They've done cerebrospinal fluid studies. The only thing that was found there was methyl tetrahydrofolate being moderately low. Normal total workup, Ativan up to 14 milligrams seemed to help at first, but then he became sedated and began to urinate on himself. So I sent him for ECT in his hometown. He was given TMS. Seemed to result in improvement in his depression, but not in his catatonic type symptoms. He's now on sertraline 200, Zoloft, clonazepam, and it should be 1 milligram rather than 0.1 milligram. And he's just now, and his family have just now contacted our person here about trying ECT. So I'm going to shift gears, and this is a little shorter presentation than the last one, and I hope you're saving up questions about this last one and this one. But I want to talk about affective mood instability. I think we're increasingly finding that's one of the things that brings kids with autism into our practice, and probably most kids into our practice, that it's this emotional dysregulation. It kind of leads to what we refer to as meltdowns. It usually occurs rapidly and is highly reactive. It occurs not only in autism, but with the broad phenotype bipolar disorder and in other developmental disorders. But it's not like bipolar, or we'll talk about some parts of it that aren't the same. It may occur impulsively, but it's not the same as impulsivity. It's this mood kind of instability. There is a really bright researcher at NIH, Ellen Liebenluft, who began to feel that sometimes we were overcalling bipolar disorder in kids, that we were identifying it more often when some kids had mood dysregulation, but it wasn't with the waxing and waning that one sees in bipolar. And it also seemed to be associated with a lot of irritability, hyperarousal, sometimes associated with ADHD, and that those were a little different kinds of kids. She started to study this more and more, talking about it being distinct from bipolar and maybe even the long-term course being distinct. So it wasn't like it led to bipolar disorder. It was somewhat distinct. And she did enough studies that the DSM-5 agreed that they should have a category, DMDD, that refers, or that is defined by severe temper outbursts, at least 3 times a week, sad, irritable, or angry mood almost every day, reaction way bigger than expected. Children must be at least 6 and not older than 10 and be present for at least a year and have difficulty functioning in more than one place, like home and school. The treatments that have been suggested include stimulants, especially if there's ADHD present, antipsychotics, but increasingly people thinking a little bit about mood stabilizers for this group. And sometimes people have said, why are these distinctions important? If these kids with DMDD sometimes look like oppositional defiant disorder, or they may look for brief times like bipolar disorder, why does that matter? Well, to predict the outcome makes it important. Meaningful research about the etiology and biomarkers, and then thinking about treatments and treatment targets become important for us to kind of separate these out. We've seen an overlap between autism and bipolar affective disorder. A systematic review of 20 mostly recent papers showed a very broad spectrum of bipolar affective disorder and autism, which occur at a mean of about 7%, with ASD also having bipolar affective disorder present. More recently, neuroimaging, studies of inflammation, maternal infection, and other studies suggest the possibility of shared biologic factors between these two. And I didn't mention genetic studies, but there are genetic studies, again, that suggest some similarities. And I think increasingly we're saying that these end result diagnoses are based on symptom clusters, but not on etiologies that might intertwine in different ways and come out in different kinds of disorders. So it's not saying bipolar and autism are the same. It's saying that for some reason they share some parts that are the same, and they share some parts that seem to be different. There's also been studies looking at the overlap between ASD and DMDD, with youth with DMDD showing excessive negative emotional responses to frustration, difficulty adapting, and similar reaction to frustration is seen in kids with autism, oppositional behavior, and mood dysregulation. But currently, the DSM says if you have DMDD and autism, you only diagnose autism, you don't diagnose DMDD. And yet studies looking at DMDD and autism are saying that they seem to co-occur in the mid-40th percentile. So it's not uncommon, and yet not all kids with autism have it, but it's an issue. It's an issue that brings kids in, and that we try to think about how can we best treat them. So 45% of children with autism experience DMDD, compared to 3% in the general population. In a study of kids 2 to 16, they also found that they do not differ from preschool children with autism as they differ from kids with ADHD and oppositional defiant disorders. So DMDD and autism may be somewhat unique, but it's not totally unique. And despite this high prevalence, there have not been studies really looking at treatment options for this subgroup. So I'll tell you about 2 more cases, then bring it together with some ideas, and then have about 10 minutes for discussion. So first case was a young man, he's now in early 20s, kid who was born to a 23-year-old mother with an unclear medical history and adopted by his current parents. He had diagnoses of autism, ADHD at age 6. He had increasing anxiety, OCD, intrusive thoughts at age 14. Medications tried by me and many others include risperidone, aripiprazole, quetiapine, ziprasidone, clonidine, guanfacine, all with modest benefits, but some with anticholinergic effects, where he would get agitated and feel jumpy inside, or may even seem somewhat manic at times from some of these medications, especially SSRIs when they were tried, like sertraline, escitalopram, fluoxetine. But it did make the irritability worse at a dose high enough to help with his OCD. He's been through 5 special schools. Being through, he was there for a while. They said, sorry, this is beyond us. You need to find something else. Currently, though he's been moderately stable, he's done the best on asenapine. He tried olanzapine, but it didn't make it better, and lamotrigine, but not of clear benefit. But he's currently on asenapine and lithium, 1,500 milligrams a day. And he's doing relatively well. My diagnoses are autism spectrum disorder, DMDD, and OCD. And I wanted to add in an SSRI, but I worry about that in terms of making him agitated or more manic. The next is a girl that she was first seen at the autism clinic at age 11. She was adopted at 5.5 months, which was believed to maybe have been substance abuse exposed. By age 3, she was not interacting socially, becomes very anxious and moderately depressed in new situations, phobias and fears. We'd first diagnosed psychosis, NOS, ADHD, PDD-NOS, borderline, tried risperidone, clonidine, Focalin increased her anxiety. And she became manic on sertraline. She's been hospitalized, tried on other antipsychotics, valproic acid with modest benefit. She's been doing well on the past 3 years on Abilify, bupropion, quetiapine, and lithium, diagnosed with autism and DMDD. So I'm going to move into discussion, which will take about 5 minutes. And I'm going to start with a diagram that if any of you have heard me talk before have probably seen, because I overuse this diagram, but I like it. So the idea is, if we were to think about the symptoms that people have or how people develop something like autism, you can look at the symptoms as though they're the surface of the earth. They're the outside of what you see. Or the center of the earth is like our DNA, but the action is happening in between. I'll try and make the long story short, but my wife is French, and we were visiting our daughter who was living in France and is married to a French guy, or got married to a French guy, and we went to visit his parents who lived in Alsace, and they said, you want to go visit some wineries? And I said, well, sure, that sounds great. And so we went to the different wineries, and each place they told us how what made their wine so special was the terroir, the way that all these different layers worked together of the earth. It was the soil in the Alsace-Lorraine that had been created by glaciers scraping through, and the amount of clay and lava and sand that were there, but also the amount of sunshine and water that the grapes got, but also the souls of the parents, of the people tilling the soil, that also went into making that. And I thought, well, you know, that's how kids grow brains. What if we could think about making interventions at each layer rather than just one layer at a time, and say, how could we think of everything that we could do to help kids do as well as possible? So if we think about layer one, we're thinking about behavioral interventions, family support, structure, 2, speech and language, OT, CBT, layer 2 and 3, pharmacotherapy, layer 2, biomedical or epigenetic kinds of interventions, and then probably not in the near future, things like gene modification that might change things. So I began to think about this and thinking about every layer, but I always like, as much as I can, to think about what could you do for that layer 2? What could you do for the epigenetic effects, the way that genes are expressing themselves? How could you create healthier soil? And think about treating immune abnormalities or oxidative stress or excitatory inhibitory imbalance or the microglia. How could we do that? Not necessarily all by itself or in isolation, but in a way of saying we're trying to create the very best terroir for this child to grow the very healthiest kind of brain. And as I think about layer 2 in these 2 disorders that we've been talking about, I'm thinking about themes like inhibitory and excitatory circuits, which happen in ASD, that we see just with ASD, but we also see them developing in catatonia, and we see them happening in certain ways with DMDD. Could that be what's happening to these kids as they get into a little bit older age, and is a kind of second wave of change that's occurring with their autism? And imaging studies have shown that GABA and glutamate, this excitatory inhibitory neurotransmitters, are associated with the severity of the social impairments in autism. And catatonia is also characterized by this GABA dysregulation, as we talked about before in thinking about benzodiazepines. So GABA is an inhibitory neurotransmitter, glutamate's an excitatory one. Lithium reduces the excitatory side, the glutamate, but it increases the inhibitory side, like GABA. And I described a few cases where lithium seemed to make a difference for these kids. And it gets suggested for catatonia as well, but hasn't really been tried as often. Valproic acid also increases GABA and might be considered. But there are several new agents that are being trialed right now, introduced by pharmaceutical companies, trying to look at GABA for a treatment of autism spectrum disorder and whether it can make a difference. We also might think about inflammatory markers that are happening in autism, in catatonia, in bipolar and depression, and possibly in DMDD. And some of the more supplement type interventions that we can think of that affect inflammatory biomarkers are things like melatonin, vitamin D, non-steroidal anti-inflammatory agents, curcumin, and they reduce inflammation. So for a number of parents that I see, I suggest to them, you might consider these. I don't think they're going to make big differences, but for parents that I'm seeing, just kids with autism, but especially a kid with DMDD or a kid with catatonia. Antipsychotics and antidepressants also reduce inflammation, so that's another alternative, but still kind of a more traditional thing. And the final thing I'm going to present is just an interesting study published a short while ago, looking at the benefit of Celebrex, a medication that's used to treat inflammatory diseases like lupus or arthritis or others, and found that they had different levels of a translator protein, those who responded and those who didn't, of this anti-inflammatory drug. So that inflammation seemed to be decreased. So I'm not necessarily suggesting these. Like I said at the beginning, I wanted to kind of leave time for us to speculate about, what do you think about this idea? What ideas do you have? Those of you who are thoughtful parents working with your children, those of you who are practitioners, those of you who might be researchers, what could we think of doing to understand these dysregulatory disorders that we're seeing now and how we could intervene?
Yes, I was asking, one of the early questions that we received was about CBD. And I know you didn't really touch on that today, but there were repeated questions about it. So I wondered if you had any insight or if it's something that you've seen used in practice.
You know, I have a number of families that are using CBD for their child that might have mood dysregulation. I've not ever seen it used for catatonia. No, I guess I have in one case, it didn't help. For some of the disruptive behaviors, even sometimes things that look a little like bipolar, I'd say half of my parents report benefit from CBD, and if they find a knowledgeable dispensary that can help walk them through the ratio of CBD and THC and what seems to work best for their child, that seems to be helpful to them. I've found many parents start off using it and then they seem to use it less and less. I'm not sure why that is, or maybe I see them less and less and they don't come in as much. But some that I talk to that are not doing well come in. I think we need studies of CBD, and there are some going on, but for now, the medical community isn't really able to judge CBD or THC or the combination because we don't have a medical literature to refer to. We don't have well-done trials, and we all know of the difficulties that have come about from not having good trials guiding our practice. So I'm not opposed to parents trying it. I say I'd like to know how it works. Come back and tell me. I'm not, when it used to be not available in California, I'd prescribe it for people. I'm willing to see people give it a try, but I'm cautious about touting its benefits.
All right, thank you. This question, I think in part they're asking a question to address your sort of challenge at the end there. This person's asking, first, can DMD be developed at any time in the lifespan? So do you feel that typically patients really exhibit from birth, or is this something that's triggered sort of like pandas? Or so that's the first part. Another question sort of related to that was from another person who's a parent, and she was just asking about this overlap and the sort of a confusion between DMDD and depression. So those two things being sort of intertwined and confusing, and do you need to tease that out?
Yeah, the first that had to do with what about it appearing later? In the people at least that I've seen, there was, I would say that there are a few that in later adolescence, even early adulthood, they begin to look more and more like they fully meet the criteria for DMDD. And yet the criteria from the DSM says it happens before the age of 10. So I think they put it in DSM-5, and Dr. Liebenluft was kind of putting these things in just to have a marker to say, how can we better define this? But my impression, especially in autism, and maybe it's not DMDD, but it's something else, but I've seen a number of kids in their early 20s, late 20s, that their disruptive mood is just becoming a target for treatment, and it wasn't when they were 10 or 12. And yet there are others that I'd say, yeah, it was a problem. Now they're bigger, they're creating more problems, and so now it's more for an intervention. The teasing it out from depression, I think, is an important part, although often what leads people to think more about the DMDD is that they see the depression, they see the irritability, and they try an SSRI type medication, and the person gets worse. They get activated, they get hypomanic, they don't do well. And so then somebody says, well, maybe this is related to bipolar disorder, but you say, wait, they don't have the mood fluctuations, they don't have the ups and downs and the periods where they're euthymic. So maybe it's something else, and that's kind of where the DMDD, along with ADHD, that's the studies that have been done talk about. It's important when you're thinking of that diagnosis, but you also think about depression and treating it, maybe after you've put them on a mood stabilizer, and that you think about using a stimulant medication or something else to treat ADHD. But often it's that whole cocktail together that people are suggesting.
This question is about, and you may have said this percentage and I missed it. They're asking about the success rate of ECT. So how frequently it is successful, if there's any data on that, and there may not be.
Yeah, I don't know of any success rate that talks about long term. I mean, so the studies that I listed there, I'll talk from the two main people who know about catatonic autism, say that they had really good results, but they don't talk about the results. And I described one of the cases that would have been in his case series that came back and was later diagnosed with schizophrenia and in a long-term treatment program in Utah. So I think there hasn't been long-term follow-up to know what is the long-term benefit from ECT. And while it would make me cautious, I still find these parents, this one boy that I didn't spend enough time describing, it just breaks my heart when I see parents that have tried absolutely everything they know to do, and they can see that he's just not there. He's there underneath, but the outside's not doing well, and they want to try anything before they say this is going to be the way it's going to be for the rest of his life. So I'm not pushing it, but at some point I get there with families to say, I don't know, maybe it'll work, but I haven't seen it work.
All right. Some people are asking about, they've been suspicious of the symptoms of catatonia, but they really are not certain if their child needs further workup. So do you know of any resources online or videos where people would see that? Person's also asking about eyes rolling back, which sounds like seizures, but yeah, there's a lot of curiosity about how it presents.
Yeah, I think you can find a number of sources by just going to your search engine and putting in catatonic autism. I think there are even some videos of that, and I think these two doctors that I described have sites that describe their information, and reading their studies, which I think you can often find at least the abstracts for by using your search engine. And if you have access to a university library, or I'm not sure that these are open access things that you could get the whole article, but there is a fair amount online. I think you have to take it with a grain of salt, but you can still get an idea.
All right. So one person's asking about the connection between sleep disruption and catatonia. So is there a identified distinctive phenotype for that, or is this just incidental?
I don't know of a distinctive phenotype for the sleep. In my experience, the sleep hasn't been so disrupted. If it's really disrupted, then it leads to think about other things on my list and the differential diagnosis. But I'm not aware of sleep disruption being a prominent feature of catatonic autism.